Hello everyone. This is a video of laparoscopic low anterior resection for a case of mid-lower rectal cancer. So at a 76-year-old lady present with bleeding PR for 3 months and on PR rectal examination there is a growth in 7 cm on anal margin. It was moderately well differentiated adenocarcinoma and clinically radiologically it is T3N1. So she has received long course neoadjuvant chemoradiotherapy, and after 8 weeks I have taken her for laparoscopic low anterior resection. So after going inside, there was and gross adhesion because of the multiple previous surgeries. So I've done the adhesiolysis, and now I'm going into the semi plane just below the inferior mesenteric vein. So you can see I'm with my left hand instrument. I'm lifting off the inferior mesenteric vein near its root and trying to get into the semi plane along the Told's fascia. So the idea is to mobilize the left splenic flexion mobilization first, along with the descending colon mobilization. So here, getting into the vascular plane at the very beginning is very important. So very cautiously and gently, getting into that same plane. So below is the gyrotous fat and above with the mesocolon. So you have to go in between these two planes. There is a loose areolar tissue plane. You can see the white line of Told. So following that plane, starting from medial to laterally, I'm going to mobilization and I can reach up to the lateral abdominal wall. And once it is done, so inferior mesenteric vein is a regioflexure and inferior mesenteric vein is skeletonized. So inferior mesenteric vein, dissecting inferior mesenteric vein has no oncological benefit in rectal cancer patient, but it has to just to gain the adequate length, because as the anastomosis after dissection will be very low down, so inferior mesenteric vein should be divided at the root. So after proper ligation, the one and division, the gauge piece is placed behind the mesocolon, and now just above the lower border of the pancreas, the mesocolon, the transverse mesocolon near the root is divided and the stomach can be seen. So that is the stomach wall. So there is a laser sac has been entered and another gauge piece is placed in the laser sac, and then a little bit of further mobilization is done along the direction of the splenic flexion. So splenic flexion mobilization is a very important part in LAR and ULAR operation, particularly where the spleen should be mobilized nicely and it should be brought down completely, mobilized completely of the left upper quadrant. And then the focus is turned towards the down near the pelvis, and the peritoneum on the right lateral aspect of the rectum is inside just 2 cm above the sacral promontory, and you can see that I have entered into the loose areolar tissue plane, which is the holy plane of Hild in between the fascia propria and the presacral fascia. So once we get into the TME plane proper, TME plane, the further mobilization of the rectosigmoid and upper rectum is done. Following that plane, safeguarding the hypogastric nerves behind, and medial to lateral mobilization was done to mobilize the upper rectum, safeguarding both the ureters. So here you can see a clear loose areolar tissue plane can be seen where it is avascular, and this is the left ureter. You can see the movement of the left ureter can be confirmed, and you have to go above the left ureter for further mobilization. As here, this is the inferior mesenteric artery, and the first branch of inferior mesenteric artery is the left colic artery. So here, safeguarding the just distal to the origin of left colic artery, I have dissected this. This is the origin of left colic artery, just left to my left hand instrument. So I am just distal to the left colic artery. I have dissected all the lymphofatty tissue towards the specimen and divided the inferior mesenteric artery just distal to the left colic artery. Now further medial to lateral mobilization is done, and one gauge piece is again kept just below the rectosigmoid area, and then further lateral mobilization is now then started. So starting from the rectosigmoid area, sigmoid colon is being mobilized of the lateral pelvic wall, which is being attached, and the descending colon is also mobilized. So you can see the mesh of the composite mesh, because the two patient underwent 2 times IPOM plus repair because of recurrent Spigelian hernia. So initially when I entered into the abdomen, there was a gross adhesion of the omentum and the bowel with the composite mesh that is being placed. So it took me almost 1 hour to do the proper adhesiolysis, which is not being showed in this video, but that meticulous adhesiolysis was done to expose the intestine, colon properly, so that I can do the surgery. So here you can see, staying into the correct TME plane, I have done the procedure with the dissection, and laterally the left colon is being completely mobilized, and both the plane is merged. So here also the same plane is being identified while doing the dissection, the same plane that has been created from the medial aspect. Now you can see the gauge piece is being exposed, so which was kept through the medial aspect. So the complete mobilization is being done gradually, and complete left colonic mobilization along with the splenic flexion mobilization is absolutely necessary. So here a little bit of final bit of mobilization. So it is being now can be seen the complete mobilization. So once we get the gauge pieces that we have kept in the initial phase of dissection, it confirms the complete mobilization. And final bit of mobilization to mobilize the splenic flexure of the colon, you can see. So I'm just dividing the greater omentum, and the splenocholic ligament now can be seen, which is being divided. Here. So once we divide this splenocholic ligament, the splenic flexure of the colon will nicely come down. Here you can see the complete left colonic mobilization is done, and staying in the avascular plane. And now the again the dissection is continued in the TME plane to mobilize the rectum. So in the same TME plane, but the thing is, as the patient has received chemoradiotherapy, so the plane is edematous and little bit adhered. Post radiation changes were there with the fibrosis and everything. So the plane I'm trying to get into the avascular plane. So till now it was not very troublesome to get into the proper plane, but as we go down further towards the deep of the sacral hollow, so now the edematous, lot of edematous fluid and the fibrosis I had encountered, and that is being carefully dissected. So the focus is to stay into the correct plane and not get into the mesorectal fat. In that case there will be oncological compromise. So even if there is post radiation changes, so very cautiously, slowly, if we follow the proper plane, we can actually do the adequate dissection. So going further down posteriorly, here this is there is gross fibrosis in the lower rectal part. Then the lateral mobilization, the lateral ligaments were identified and divided. Safeguarding the ureter, which lies more laterally. And then the left lateral mobilization is also being done by dividing the peritoneum and staying into the same TME plane that is being created from the medial aspect, from the right lateral aspect. So this is the left lateral aspect mobilization. Patient underwent also THBSO, so 2 times laparoscopic IPOM plus. Patient underwent also THBSO, so there was little bit of pelvic adhesions were there also because of that. And patient underwent laparoscopic cholecystectomy, open appendectomy, so there were multiple surgeries in past. And so there was some postoperative adhesions, some adhesion because of the radiations. So these are all difficult situations, but if we know which plane to proceed, then we can identify. So anterior peritoneum is also being divided, and the rectovaginal plane is being entered. So anteriorly we can see, so safeguarding the posterior wall of the vagina, the rectum is being mobilized and brought out of the pelvis. So one assistant surgeon who is sitting at the near the at the bottom, he is actually pushing his finger through the rectum and the assessing how much mobilization is required beyond the growth. So the idea is to at least get 2 centimeter of margin below the growth, distal to the growth. And as the growth was 7 centimeter from anal varge, and ideally this patient need laparoscopic low anterior resection, and so lower down the dissection is difficult, but safeguarding the vaginal wall is also very important. And then I am doing the lateral dissection, dividing the lateral ligaments. So here you can see the levator ani is being getting exposed, the pelvic floor is being getting exposed all around the rectum, and complete mobilization, almost complete mobilization is done, and it is being confirmed that I have reached beyond the lower limit of the growth. So at least 2 centimeter margin is required, so that we can fire a stapler once the mobilization is being done. Now once I have reached the 2 centimeter below the lower rectum, now the idea, then the next step is to trim the mesorectum all around so that the rectal wall is being exposed nicely 360 degree, and I can fire the stapler. So here cautiously the rectal wall is being skeletonized. Here the rectal wall, you can see the once we divide the mesorectum, the rectal wall is getting exposed, and now a 60 millimeter cartridge is being placed and confirm that the stapler is being placed beyond the lower limit of the growth by per rectal examination. And this is a green cartridge. So this is articulating endo-GI stapler, and this one fire stapler is being fired, and another is being fired to complete the division. So now you can see the divided rectal margin, there is no bleeding. So, and the pelvis is absolutely bloodless, so there is hardly any blood loss during the whole process of dissection. And now after after the specimen is being extracted through a incision in the left iliac fossa, this anvil is being placed, and the bowel is pushed back inside, and through the rectum the circular GI stapler, there is a 29 millimeter circular GI stapler is being placed, and the anvil that I have placed inside the distal part of the colon is being connected, and colorectal anastomosis is being done, and the Ehrlich test is being confirmed after that. So patient had an absolutely uneventful recovery. Guarding ileostomy was done after this part, and the stoma started moving on postoperative day 2, and patient was discharged on postoperative day 4. The biopsy report came out to be YPT2N0 with 34 lymph nodes are negative, well-defined carcinoma, all margins were negative. Patient is on adjuvant chemotherapy. Thank you so much for watching.